Hi, I'm Laura Carroll with CompuMed. And on behalf of the entire team at CompuMed, welcome to our expert webinar series, where the featured topic today, as you all know, is bronchoscopy and donor management. CompuMed is really honored to have Dr. Luis Angel to present this really important topic. Dr. Angel's in-depth knowledge and expertise really helps in assessing, managing, and improving the recovery of donor lungs and resulting in an increase in the number transplanted into the needy recipients. We're really grateful for his passion to share his knowledge and expertise with the entire OPO and transplant community. We're also real quick wanted to let you know that Carrie Cadrick, who is currently a VP at Southwest Transplant Alliance, is on with us today. Carrie was just recently with the CompuMed team for over 2.5 years, and prior to that was with TOSA for, Carrie, 20 plus years. That dates both of us. And she actually was instrumental in introducing us to Dr. Angel, as she worked with Dr. Angel when he was based in San Antonio. And both of their passion, they talked to each other and knew that this was the right thing to bring to the entire OPO and transplant team. So this is where we are now, and we're excited to have you. And again, welcome on behalf of the entire CompuMed team.
All right, thank you very much, and welcome to everybody that is participating in this webinar. As Carol nicely introduced me, I'm a pulmonary and critical care physician, currently the director of the lung transplant program at NYU. And before that, I was in San Antonio with the University of Texas Lung Transplant Program, where we work very closely with TOSA in implementing some donor management protocols. And what some of you may have heard before, the San Antonio Lung Transplant Protocol, or the SALT protocol, which again has been implemented by many of the OPOs in the management of organ donors, and it's something in which I have a lot of passion and have done a lot of work and research in trying to improve the availability of organs for our patients. So what we'll try to do is give an overall view of lung transplantation and organ donation, and then focus a little bit more on detail of the role of bronchoscopy in some of the challenges that we have in the management of potential lung donors. We'll try to spend 25 minutes or so on the presentation, because I think that it's more important to leave an open forum for many questions and try to answer topics related to lung donation. So I always like to start with giving a big picture of where lung donation is. And to me, something that I try to describe to most of the OPOs, if I say I was a person that is giving a task of review an OPO. And there are, again, multiple things that you can measure the performance of an OPO from the clinical point of view. I will say that my choice will be, let me check at this OPO and see how are they doing with lungs, because that will give me a good indication of how is the management of the donors that they have and how complicated it is. So this graph shows a little bit of that data, and you see different colors in here. So in this line here is total disease organ donors. Here is kidney, liver, heart, and lungs. So first of all, you can see, again, few things that are interesting. Again, obviously, since 2014 and 15, we have a significant increase in the total of organ donors available. As you can imagine, again, you see these two lines here, the kidney and the total organ donation, they really match almost perfectly all the time, which is basically telling you that if you have an organ donor, you have a good chance to be able to procure the kidneys. And in some way, there is not a lot of management that you can do, or it's not a way to measure, again, your management, because most of the OPOs do relatively well with kidneys. With livers, it was almost the same story, but I think that because some of the donors that we are taking are a lot more extended, the curve is a little bit different, but also the chances is if you have an organ donor that you're going to get, again, a kidney or liver. And truly, again, different than the hypernatremia and the overall good management of donors is not much that you can do also for the liver. Then down here, you start seeing, again, just the heart and the lungs. And you can see, again, the numbers here, how they start increasing over the years. And here in 2019 and 20, probably some of this is related to COVID and all the things. We just kind of see that kind of plateau here. But this is almost like a different way to look at the same graph. Again, purple here will be all the donors, kidneys, and livers. So you see how, again, as you increase donors, you're always going to increase kidneys and livers. But for lungs, again, the numbers increase some way. But even if the number doesn't seem to be a huge number, for organ donation and lungs is very, very significant. Because in 2007, we were doing 1,300 donors, and this started increasing. In 2015, we crossed 2,000 donors for the first time. And then in 2019, and then for the last 3 years, we are doing 2,700 donors. So this is a significant increase in the number of donors that we are doing. And a lot of this is related to better donor management, which I think that is most of it, but also to some of the programs that are becoming more aggressive and more comfortable taking extended donors. So some of the reasons why it's so difficult to procure lungs and it's so difficult to go into different hospitals and manage this is because there is this kind of confusion on what is important in terms of lung donation. And even if this criteria has been established for a long time, most of them are really mixing a bag when our coordinators, when we are taking care of the patients, and more importantly, the ICU teams, they have no idea what is required for a transplant program to take some lungs. One of the first examples is when you make a lung offer, and usually they come again in the middle of the night to a transplant center. The first things that the surgeons or the pulmonologists who are taking the offer are going to ask is, what is this PFR? This ratio between the PiO2 and the FiO2, and you want to be more than 300. So you are measuring blood gases in 100%, that is my recommendation. In that way, you have a consistent numbers to look when you are reviewing in DonorNet and not all of these different PiO2s. Because again, people don't make the effort to look at the PFR, they look at the PiO2. But if you look at this number, you want to be more than 300. This is a goal that none of the ICUs that is taking care of living patients in mechanical ventilation has, and which very often make a difficulty for the coordinators when they go to somebody that is starting 98% with a PiO2 or PFR of 200, and everybody's as happy as they can be on that ICU, and you start saying, we need to do a lot of stuff. We need to, again, do changes on the bronchoscope, do recruitment, get new x-rays, do a bronchoscopy, because we have this sense like, okay, these lungs are not good for us. But up to the point that the patient became an organ donor, I can almost guarantee that the ICU team was super happy because they have a PiO2 above 150. So this is an absolute criteria that is very important. It's not to say that we haven't taken patients with PiO2s below 300, but for the most part, if you want to be offering lungs, you need to improve the PiO2 and the FiO2 ratio to above 300. The second criteria is about the x-rays. It's almost impossible to have a completely normal x-rays. But some of the things that you see on the x-rays of these patients can be improved, again, by management of the donor, like atelectasis with cleaning up mucus plugging, or if there is, again, a minor contusion that we know about the trauma, I think that we can live with those things. But we want to improve the x-rays. And there are very few ways to improve the x-rays, but most of them are very successful, and I will go over those in a few seconds, but they may include the bronchoscopy too. And finally, you want to have a clear bronchoscopy with no evidence of aspiration of purulent secretions. And also you want to have a negative RAM stain and now a negative COVID test. And for those things, you are required to have a bronchoscopy done. Other things are why we consider extended criteria. And many of those things are things that you really cannot do anything for the donor. So for me, almost the absolute criteria that are the things that are required are things that we can work on. But the extended criteria, very often we just cannot do anything because a lot of this is the history of the patient. We cannot make them younger. If they were heavy smokers, we cannot just can make them non-smokers. If they have history of pulmonary diseases, in particular asthma or something like that, or COPD, we cannot take it away. If they came with a major chest trauma, it just happened. And this, again, peak pressures, we can make some changes. And the negative Gram stain, that one is not a criteria anymore. Most of the Gram stains in our patients are positive. But what is very important is that we start antibiotics really early in all the donors. And my personal recommendation is every donor, regardless, should be on antibiotics because, again, the argument I always tell our coordinators when we do simulation and training courses or when we take care of our donors here in New York or when I was in Texas is those same lungs, immediately when they go into the OR, we are going to give antibiotics to our recipient. So there is no reason not to give it before because they are going to be getting these antibiotics. Now, to make things very simple and realistic, when we have this, what I call the three biggest enemies of lung donation is when you are looking into this absolute criteria of getting like a very good PFR or PaO2 above 300, and you want to have a relatively clear X-rays, the things that give you this type of trouble are pulmonary edema, atelectasis, mostly of the lower lobes, and pneumonias. So those are the three things that you need to look into. And bronchoscopy will have a significant role in the management of the atelectasis and then also in the diagnosis of pneumonia and looking into the purulent secretions, getting the cultures and providing some information that show you again how important it is to do a good BIL to reassure the transplant center that regardless, even if there is a little bit of an infiltrate, the airways are looking good, there is not a lot of purulence. When you do a good BIL, again, you clear up the airways and then you see the return start coming clear and the secretions are not reaccumulating. And also it's very important to do this fairly early because we always want the patients to be on good antibiotic coverage at least for 24 hours, ideally for 48 hours. So you tell me that you have a donor with a single lobe pneumonia, and we say we documented what the bacteria is, and we have antibiotics for at least 24, 36 hours, and the bronchoscopy looks good. This type of donor, we will take it here. And we have done many donors with these characteristics. But again, the results of an early bronchoscopy are very, very important for us to know that this is getting better. So because we know that the X-rays take longer to improve compared to the purulence on the airways. So you can start cleaning the airways and the X-ray may lag behind. So that part is very important for us. And the atelectasis of the lungs, if there is mucus plugging, you can do all the recruitment that you want by the secretions are plugged with air, with mucus. All the recruitment is going to go to the other areas and you cannot expand those unless that you clear up the airways. So from these messages, I think that you can infer at this point, or you can start saying, it's very clear that, again, Dr. Angel feels that the bronchoscopy should be done as early as possible to clarify, again, these enemies of organ donation, the role of atelectasis and mucus plugging, and define if they have a pneumonia based on the X-rays and the bronchoscopic findings. Remember, again, hypoxemia for us when we are taking of organ donors is 300. And if you leave that message to the bedside nurses in the ICU, specifically to the respiratory therapists and even more to the ICU attendants there, because this is why I see all the time, they question, why are we doing this? When somebody has a saturation of 97% and a PO2 of 150. And because we say for organ donation, hypoxemia is a PFR less than 300. And this normal pulmonary infiltrates, again, we can help with this with very good donor management. So one of the first things that we can do is obviously, we can spend another time in a different meeting about the management of pulmonary edema, but it's probably one of the most common things I see on most of the donors. These patients, they have been resuscitated very heavily, very often when they arrive into the hospital. Once they determine that the patient is very, very sick and probably gonna die, they just stop the resuscitation offers, but they forget that they have the patient 10 or 15 liters up, and then we need to diurese them. And very often they just not forget that they give the 10 liters at the resuscitation, they keep giving fluids for 3 or 4 more days. So I assume that most of our patients are volume overload, and trying to diurese here, what we are trying to show in this graph is that at some point, and it's usually again 2 or 3 days into the resuscitation of the patient, that is around the time that we have the pronunciation of brain death, giving more fluids usually does not help improving of the cardiac output and the hemodynamics. All it does is increase the extravascular lung water. And unfortunately, the most leaky of all the organs that we have when we are taking care of organ donors are the lungs. And so I will say the calculation that you need to make is for every liter that you give of fluids, approximately 500 to 600 of those fluids are going to find a way to get into the lungs. So it's a significant amount. So we have to be very judicious with not giving a lot of fluids. And in patients that we can diurese or dialyze in some of those, we have to do that. The pneumonia is a very important thing. There is not much that we can do. Again, if they already have a pneumonia, but there is some things that we can do to prevent pneumonias. So we always need to have the head of the bed elevated. I always tell all of our coordinators, inflate the cuff to the point that the respiratory therapist is uncomfortable, that it feels really hard, because we don't care about creating any kind of tracheal issues. We don't do tracheal transplants yet. And that will be extremely rare. And we want to avoid that any aspiration, especially patients with trauma when they are bleeding from the face or from the head, or patients with gunshots to the head, or major trauma that they are having brain particles even staying on the back of the mouth. They can aspirate these things into the lungs. So just overinflate the cuff. And then we go into the question with the antibiotics. Our recommendation is for most of the patients with vancomycin and cefepime, vancomycin and Zosyn, but you can use linezolid, but all of these patients should be on antibiotics, is my recommendation. The one that we missed the most is this, is the atelectasis. And unfortunately, this idea by critical care physicians and by most of the people taking care of these patients, that having a little bit of atelectasis is okay. And especially the PiO2 is fine. And because they look at an X-ray like this, when you can see the diaphragm very clearly here, again on the left side, but you lose the diaphragm on the right side, and you see this area collapse here. And then you say, okay, there is some atelectasis on the right lower lobe. Truly, when you have a right lower lobe collapse, you are missing at least 50% of the right lung function. So even if you say, oh, it looks fine, again, I see this X-ray looks fine here, and this is mostly okay, you are giving a significant amount on the lung function there. And even if, again, you see a complete collapse on this X-ray here. On the left side, again, the same thing, you see this dense retrocardiac area, and then it's complete collapse of the left lower lobe. And then again, you are giving 50% of your lung function. And that can make the difference between a PiO2 280 and 350. Which makes from a poor donor to a good donor. And often these atelectasis like this are due that the patients are being on the ventilator with low pressures, because this ARDS ventilation is what everybody uses with extremely low tidal volumes, high respiratory rates, and they don't have a lot of PEEP. This is the patient staying in the bed for 3 or 4 days. He's basically dying, nobody is rounding, nobody is suctioning, and doing all of those things. So the most common problem in donors is atelectasis of the lower lobes. And if you have atelectasis of both lower lobes, then you are giving easily 100 points on your PFR. And now most of these atelectasis are due to mucus secretions and plugging, and recruitment can help a lot, but the secretions are very significant and the bronchos are occluded with secretions. It doesn't matter how much PEEP you use and how much recruitment, you will not be able to open those airways. So when the reports say that there is atelectasis, then it's very important to look into the airways just to be sure that they are clear, because if not, again, the recruitment will not work. If they are clear, then the lung recruitment has a better chance to help us in opening those lower lobes. So some of these x-rays, this is the problem very often, that we just see, again, these reports by anesthesia, by radiology, that after the patient has been there for 3 or 4 days, first of all, they say no significant changes. And they are always going to describe there is some pulmonary infiltration on the basis, cannot define atelectasis versus pneumonia versus fluid overload. So we really need to look at the x-rays, and it's always something that we teach in our simulation courses. We teach to all of our coordinators how to read donor x-rays, because it's really important that you determine and you look into that to say, you know, there is all of these infiltrates, and I'm not sure if it's pneumonia or atelectasis. The bronchoscopy will help you a lot, because the bronchoscopy, you see mucus plugging, you clear the mucus and there is no purulence. Probably kind of is going to help you lean a little bit more like, okay, I think that we are dealing with atelectasis. However, if you see that all the ways are opening, you wedge the scope and the BAL, it's all purulence, then you say, okay, it's more likely pneumonia what it has. Let's give the antibiotics, do lung recruitment, and see if we can make things better. So again, the same things here. For example, clear left lung. On the right lung, you can see the diaphragm. You see this dense infiltrate, so it's more likely pneumonia. And pneumonia like this, the bronchoscopy should show significant purulence on this area. And if you have antibiotics going for 2 or 3 days, maybe that the airways look fairly clear. So when you make the offer for somebody like this, maybe some interest, because you say left lung is very clear, this has been treated, it's getting a little bit better, and hopefully with some recruitment, we can make this lung look a little bit better. Again, this is the atelectasis of the left lower lobe. Again, it's completely collapsed. And that's why, again, it's very important when you see left lower lobe collapse or right lower lobe collapse and combine, you are giving 50% of each one of the lungs with those lower lobe collapses. So it's a very significant amount. So let's focus a little bit on bronchoscopy for evaluation and management of the potential lung donors. So what is the ideal time for the procedure? And this is a very, very difficult question from the practical point of view, from the clinician point of view, and from the donor management. The answer for me will be as soon as you get into the ICU to see these patients, do the things that you need to do, get your bronchoscopy done. And it's part of our donor center here at NYU. We have a donor procurement and recovery center at NYU, which started almost 1.5 years or 2 years ago, with a procurement rate of lungs close to 40, almost 50%. So one of the highest procurement rate of lungs. And whatever time they get here, middle of the night, the ICU team knows as soon as the patient is in the room and stable, there is a bronchoscopy done. So why is that important? Because as I had been mentioning before, we need to see where the line, again, how is everything looking? What can we do and try to answer this question? Why is that these lungs are not ventilating well? And we have the information of the x-rays, we have the information from the ventilator, and then if we add the bronchoscopy and we say, okay, there is mucus plugging, we clear up the mucus plugging. There is purulent secretions, we send the gram stain. So my recommendation will be to do it then. Now, the reality is most of the places are not like NYU. Most of the places don't have the resort. Again, the things that we have when I was in Texas with TOSA, that we have our own bronchoscopes that we were taking to the hospital. So we always have a bedside bronchoscope. And all we needed at that point was to get somebody there in the ICU to say, come and do the bronch. The reality that I see all the time, even here in New York, when they call me from many other hospitals, or when I was also in Texas sometimes, is that they are trying to call the bronchoscopy tech, and it's Saturday, 3 o'clock in the morning. Nobody's gonna come. Sometime in Sunday, they don't even come. And then the bronchoscopy is left with this idea, okay, everything looks fine. We're gonna offer the organs. Let's do the bronchoscopy at this point, just to kind of check box that the bronchoscopy was fine. So I think that, again, obviously you do whenever you can, but the ideal point is to do it relatively early. In that way, you can, again, find out if there is any abnormalities. The bronchoscopy can help you, and it has to be, again, a good quality bronchoscopy to do this. Obviously, we have been working in training coordinators for this. It's a very, again, huge task. But if you ask my opinion, I think that will be the best way to approach this thing, to have most of the coordinators trained. This is a very easy procedure to do in an intubated patient. And then we can basically just do the bronchoscopy, do a videotape. You guys can review with the ICU people there. We can help to review the bronchoscopies and then come up with an idea, again, how to do, again, the interpretation and what to look after we do the bronchoscopies. Once we do a bronchoscopy, there is obviously some minimal requirements. We need to understand the anatomy, and we need to describe the anatomy. Luckily for us, very, very rarely we have an anatomy that is abnormal enough that can prevent us from having transplantation. And I will never ask, again, a coordinator to be able to define the anatomy of the lungs perfectly. But the basic stuff to say there is a right lung, there is a left lung, both of the bronchus seems to be okay. That's at least what we need to say. The secretions is very, very interesting, because most of the pulmonologists or the ICU physicians or the anesthesia people that are doing the bronchoscopies, like I mentioned before, they do not understand lung donation. They think that a PaO2 of 150 is fine. And then they do a bronchoscopy, they place the bronchoscope, the endotracheal tube is plugged with blood and mucus, the trachea has a couple of big plugs, and even at that point they say, oh, this looks terrible. And it doesn't mean anything to us. Again, we don't transplant the trachea, we don't transplant the endotracheal tube. You have to go beyond these areas, clear up all of those mucus, we don't care about that, get into the lungs, clean up all their ways, do an anatomy review, and that requires to use a fair amount of saline, have a large therapeutic bronchoscope to clear up secretions. So don't use that little pediatric scope with a 2 or 3 millimeter, again, channel that you cannot suction anything. And just use a very good bronchoscope. And I say, again, just clear up the endotracheal tube, the trachea. Don't worry about that. But sometimes I have seen pulmonologists that they basically stop at the trachea. They say there's a lot of blood in the trachea. This looks terrible. And then they don't make even the effort to see how does it look. And once you clear up all of that, how things are looking. We also need to obtain samples. And these samples, again, the better that we can do is obtain them as early as possible. Or again, the donor management in most of the OPOs is 24 to 36 hours. If we have the cultures and by the time that we get the organs, we have the results of cultures, it will help our recipients and will help you to be able to place the organs. If you say the cultures are negative or it's just a regular bacteria, and nowadays, obviously, we are required to evaluate for COVID. For aspiration too, there is these patients that have, again, especially in trauma, very difficult intubations, or patients who die with drug overdose. Many of those patients can aspirate during the process. And if you find food particles or something, you can see them, you clean it up, and then you see, but you have to document all of this. I think that is ideal to, at least for the OPO coordinators, to very carefully look at the bronchoscopy when it's being done, especially, again, to avoid these things that, again, they are stopping without clearing the secretions, and all they do is play 20 cc's of saline in one lobe, and that's it. No, you need to be aggressive. Go to every lobe, clean it up. Be sure that you do that. So you are there and you are present during the bronchoscopy is fine. And most of the bronchoscopes now, you can do a videotape and picture documentation. If not, use your smart devices, use your phone and make a video and take a picture, put it on DonorNet. That will help, again, the surgeons and the team just to see how the airways look. And also the BAL needs to be described. There are some of the BALs from the smokers that looks really dark and black. So when there is a question about the smoking history and you see all of these anthracotic pigment, you may say, probably this guy smoked a little bit more than what we think. And you can see purulent secretions, you can see aspirated material, you can see a lot of blood in contusion. So you have to do this. And ideal, you take a picture. That again, because it's hard to describe to other people, but a picture will show you very quickly the characteristics of that fluid. So this is a bronchoscopy that we did in a donor, again, just last week in preparation for this talk. This is with an ambu that doesn't have the best images compared, but I just want to make a realistic donor. So here again, we are going from the right, we already kind of cleared up the secretion. So you see how everything looks clear. We are going into the right side. The right upper, I'm never expecting that you guys will have to describe the anatomy. All you have to say, hey, I see going to every opening. I don't see a lot of secretions. Now we are going into the bronchus intermedius, the middle lobe. Everything looks open there. Here, the same thing, going into the lower lobes. And then once you get into the lower lobes, you're going to wedge the scope and you're going to place, again, 50 to 100 cc's of saline. And then when the scope is wedged, you're going to try to suction. And if the scope is wedged properly, you should be able to suction most of the fluid back. So you won't be losing too much. If you put the fluid in the middle of the airway, you won't be able to get it. But if you wedge the scope, again, you will do that. And after you clear up the secretion, you see everything is very clear. Now we are going into the left side. This is the left upper lobe. Again, this is the apicoposterior anterior. This is the lingula. Again, you are seeing each one of the openings. You don't see a lot of mucus. So this one, if they have atelectasis, you say, okay, recruitment should help because there is no much secretions. And it's important, again, that the bronch looks like this, or you try to do like this in a therapeutic way. Just kind of be aggressive, clean up the airways, do these things, and then do a nice documentation of your bronchoscopy. Now, the donor management protocols, again, are really, really important. And obviously, even if we are not going to talk about all of this, I have to say that the results are really important. We have to take care of every donor. And the reason I'm showing this picture is because this is a 17-year-old patient that when I was in Texas, again, was in Austin with a major car accident. And this is the initial presentation of this patient. But we were working and we're going to take care of every donor. We're going to be very consistent. We're going to do our bronchoscopies. We're going to do the fluid monitoring. We're going to do the lung recruitment. And interesting, this donor, the PaO2, the PFR was around 220, 230 with this type of X-ray. So that kind of gave me the information that maybe that most of this was kind of significant neurogenic pulmonary edema, and that with good donor management, we should be able to clear this. Both lower lobes were completely collapsed, but the airways were open. So we knew that recruitment and diuresis could make a difference. And we start working on that. And with the recruitment, as you see, compared to these dense areas here, now we start opening the lungs, and it's still a significant pulmonary edema. And this is, again, 8 to 10 hours later. And we were able to take, again, these lungs, and as you see them. So donor management is extremely rewarding in what you can do. And from lungs that look really poorly, if you implement all the things that we are saying about fluid management, ventilator management, and bronchoscopy, it can make a big difference. We do have time. Again, most of the donors, if you see the average time that they take, again, 36 hours is the time that you have to take donors. So if we implement these changes as quickly as we get there in terms of donor management, we can make a significant difference. There is some, again, criteria for mechanical ventilation. There is some, again, recommendations for the use of PEEP. Now, one of the reasons that I want to, again, I have such a passion for this is because it's really important to get more lungs, to get everybody transplanted for lungs. And here is, again, a little bit of the story. This is looking at the OPOs from 2021. And I divided this in two different groups. So I don't know anybody that is in the call and what OPO they are. You can quickly try to look at your number here. But to me, I will say, okay, OPOs that procure 20% and above. We call this like the top performing OPOs. I think that we should be 25 and above in most of these. So again, kudos to all of these OPOs that are doing around this number. I have to say, when I was working in Texas, I was pretty sad when I, again, prepared this slide for 16 years when I was there, and we were working very hard with organ donation. Our OPO was number 1 to 5 every single year for 16 years, and now I'm seeing it back to where we start. Again, almost 20 years ago there, doing 11%. So it's so important to do it. And there is a lot of underperforming OPOs that are doing these extremely low numbers. What I think that is very important for us is if you look at the number of donors and the number of transplants, you see how many lung transplants are added to the transplant list. So you start looking over the years, again, from 2010 to 2021. So we are adding around 3,000 patients, again, hit and miss here to the transplant list right now. This is the number of lung donors that we are currently doing. So the difference, as you start seeing again, was very significant. We have like a 45% gap to close, but this gap is getting smaller. And all we have to do is get this, again, 400, 500 more donors. And if we change these numbers here from these underperforming 15% donors to this average overperforming 24%, so a 9% improvement on this, we basically wipe out the transplant list, and this deficit will be only 100 patients, which will mean that every single patient that needs transplantation for lungs will be transplanted the same year when they are listed. And there is no any other organ that we could be able to say that. Even if they procure so many kidneys and livers, those transplant lists are huge. 80,000 patients waiting for kidneys, again, 20,000 waiting for liver. So we will never get there. But with lungs, we are very, very close. And all we have to do is everybody just need to commit to make a better job, to take a better care, to move from this group to this. It's not huge. The effort that you have to make is just being very consistent in donor management, passionate about it, and also incorporate the volume management, the ventilator, and hopefully, again, after this, understand that incorporating the bronchoscopy is very, very important. So in conclusion, again, lung transplantation again, is vital for our patients. The best option to improve organ donation is, and in particular, lung donation starts at the arrival of the potential organ donors at the hospital. Like I mentioned before, many of the hospitals, they completely neglect lung donation until the patient becomes an organ donor, and then it's the OPO responsibility to do everything that they can. But you use wisely those 36 hours that you have in average, or 34 hours, I think that you can move your OPO from the underperforming to the good performing OPOs. This good communication in the transplant centers and OPOs is very important. And that's one of the things that happened in Texas too. The lung transplant program that was very active now is a very small program. So between a small non-aggressive program and the lack of commitment and communication, things can be, again, weakening in that. So it's very important. And I think, again, people keep hearing about these ex vivos, and every time that I get an offer, let's say this donor qualified for ex vivo and stuff like that, I don't have any issues with ex vivo, but I don't use it very often because I strongly believe the in vivo donor management, when the donor, the lungs are still in the donor that has a heart that is beating and a lungs that are breathing with the ventilator, is the best opportunity to manage these lungs. And we do have time to make it better. So these donor management protocols in vivo, to me, is the best thing. So with that, unfortunately, again, I went a little bit longer than I was supposed to, by 10 minutes, but I'm happy to take any questions, and I really appreciate your participation and being present on this. My appreciation for the coordinators is always the biggest I can have. Your work is very hard. You work under very difficult circumstances with many times, unfortunately, in hostile environments. And every night, every weekend, every special holiday, you can count that there is a coordinator there. So you guys have all my sympathy for your work, and anything that we can help to make this better, that will be our mission. Thank you so much.
Thank you, Dr. Angel, and thank you to all 140 of you joining us for Dr. Angel's presentation. It's amazing to see so many of you interested in donor management and bronchoscopy. Now we're going to move into our Q&A. So if you haven't submitted your question yet, the Q&A section of Zoom is filling up fast. We're going to try to get all of your questions in. Some of you sent yours in early, so Dr. Angel will be taking those first. And yes, Dr. Nicholas Henry says hello from Texas.
Okay, thank you.
So Dr. Angel, this is a question from Donor Network West, and they asked, what are the indications for serial bronchs?
Oh, excellent point, because I didn't mention this on my presentation. And this is something that we do here. And that's the reason that the first bronchoscopy is so important. Because if you have a first bronchoscopy, when you say, I'm kind of unhappy with this, it's a lot of secretions, we keep, again, getting a little bit of purulent secretions, was so much mucus plugging, that will be the type of patient that will say, okay, we're going to decide our initial bronchoscopy. We did this tonight. Tomorrow morning, I'm going to repeat and see how these things are looking. In that way, you don't have the report of a bad bronchoscopy only. You can say, this is the way that things were looking. We suction everything like that. We start the patient on antibiotics. We did some low recruitment. We suction all of this mucus plug. And then our second bronchoscopy 12 hours later hopefully looks a lot better. Or you are still dealing with issues with secretions or things like that, you can clear up. So I think that it depends on your first bronchoscopy. Your first bronchoscopy looks pristine. The blood gases are great. The x-rays are good. You don't have to do more bronchoscopies. And this is why I see the value of this. And I don't want to promote any company, but when you have these bedside bronchoscopes that we were taking with our OPO in Texas and you leave it bedside, the bronchoscope is always there. So it's not like you need to call again the team of the ICU, come the bronchoscopy team and all of those things, because then becomes a production and it's a lot more expensive too. So I will recommend, according to the findings of the first bronchoscopy, but if your first bronchoscopy is not ideal, very likely the transplant center is going to require that you have another bronchoscopy before you, again, go for the final allocation. And as you know, again, the surgeons, when they go there, they like to do their own bronchoscopy. So again, you get the benefit of having your own scopes and doing all of these things multiple times in the same case.
Okay, thank you very much. We've got another question from Donor Network West, and they're asking, what's the best way to begin lung management on a donor? I know it's not a one-size-fits-all, but a good starting point or parameters, a good direction for OPOs to begin proper management.
Yeah, so I think I addressed a little bit some of these issues during the presentation, and obviously that's a course that we have here at NYU for organ donation with simulation, that we have all the Live on New York coordinators and some of the upstate coordinators coming to take and go over all of those things. Obviously, to me, is understanding better what is required, knowing that our fight is against pulmonary edema, pneumonia, and atelectasis. And we have to do, again, fluid management, ventilator management, and bronchoscopic evaluation, assessment, and management of the airways. Now, if you ask me, Luis, you have an opportunity to say what is the best thing to do is you start these things as soon as you have time and you get there. Also, you need to get situated. You need to, again, fill all the paperwork, meet with everybody in the ICU, talk to the family, do all of those things. I do understand. But once you settle those things, you review your, again, donor criteria for lung donation. You recognize they are not ideal. And I say, I need to start working into this immediately. Very often I see that they call me at 2 in the morning and the x-ray was done, again, 6 o'clock in that morning or even the night before. The blood gas was from 18 hours before. And you just need to say, okay, this is where we go. We are going to implement management. Let's get a recent x-ray, good blood gas, get our bronchoscopy, see where we are, and start management early. Implement protocols. There is, again, multiple publications. There is a consensus statement in which I work again, and I was the author of that consensus statement on donor management for the lung section. And if you start implementing all of the things that we discussed briefly today as early as possible, that will be the most important thing I will recommend.
Okay, thank you. Now we've got 2 questions from Finger Lakes Donor Recovery Network. First question is, What is the best advice you can offer for getting a thorough Grinch without causing significant derecruitment and residual fluid being left in lungs after BAL samples that look like pneumonia on imaging?
Okay, very good. So couple of things. One is when we are doing the bronchoscopies, don't ever disconnect the patient from the ventilator to do the bronchoscopy. That will create problems because then you will lose all the recruitment, especially if you have done it for hours. So always try to do it through the adapter that you use that minimize the leak, but still you will have some leak, but it won't be as massive. The second part that you will do in terms of the BALs, and this is important to do, just try to wedge the scope when you are doing the BALs. In that way, you have a better chance to recover 50 or 60% of the fluid that you give to the patient. And also, you wedge it, again, it will be going into a more focal area. That will be easy when you are looking into the x-ray saying, yes, we did a lower lobe lavage in the lateral segment, and you are seeing a little bit of an infiltrate on that area. That's what you need to do. Now, the fluid into the lungs can reabsorb very, very quickly from a BAL. So my recommendation is you just don't send an x-ray 20 minutes after the bronch. You just try to do it again 2 or 3 hours later. And most of that fluid, even if you leave 200 or 300 cc's behind, probably will be gone by that time. Now, very often after I finish the bronchoscopies, I do a little bit of recruitment again. So what you can try to do is one of those, again, 30 over 30. In that way, all the recruitment that if you lose some recruitment, you can re-recruit, and that will take care of that part. If you want to do that, or increase the PEEP again for a few minutes, again, go the PEEP 10 to 12, 15 in some cases, and that will kind of re-recruit the lungs after the bronchoscopy. And I do this very often, not just for donors, for my lung transplant recipients, after we do the bronchoscopy, and we are trying to get them extubated or something, just not to lose the recruitment. I kind of re-recruit them very shortly for, again, a few minutes, couple of minutes, and that should do it because it's a very loss of recruitment during the bronchoscopy.
Thank you. Dr. Angel, can you go ahead and move to the next slide before we ask this other question? Thank you.
Yes.
Significant PMH of smoking. How significant is it really if the gases look good?
That one, you are going to have 100 different answers from 100 programs. I personally feel that somebody that has a smoking history that is more than 20 packs per year, and especially is getting into the older category, the donors are getting over 60 or close to 60, and they have a smoking history of 40 or 50 packs per year. You are just not taking the risk that they may have some early emphysema and things like that, but also the risk of malignancy with those patients. They may have an increased risk of tumors, and then with immunosuppression, there is a little bit of additional risk. So our program, again, when we have somebody that is fairly young, 25, 30 years old, and they say that they smoke a lot, but the most is going to be 50 to 20, I'm okay with those. With the older donors, I'm a little bit more concerned, and even if it's not the right way to do this, it's just the smoking history. It's very sketchy on these donors. Sometimes it's just there's nobody to document clearly, or whoever is with them and say, oh, I have been with them the last 3 or 4 years. I was smoking only half a pack per day, but they are 60 years old, and so they give us a story that he smoked 10 packs per year. I have a lot of questions about those. And when you have an older smoker, I always ask at some point, what is the most that you smoke? And I'm assuming that they smoke that for most of the years. But then also you have to have a CT scan. The CT scan is completely normal with no pulmonary nodules and no emphysema. I think that I feel a little bit more comfortable in somebody that is 35 or 40 years with a smoking history of 25 or 30 packs per year. If I really have a very sick recipient that is dying and we need to get organs, I may be comfortable with that. However, if the donor is the recipient is fairly stable, I will say I'm not very comfortable. With that being said, there are very often very aggressive transplant programs that they really don't seem to care much about the smoking history as far as they have good mechanics on the ventilator, a good bronchoscopy, and the CT scan looks fine. They use it, and the reality is, with information that I don't like to share with any patient. But even if you are a heavy smoker, the chance that you develop pulmonary diseases is less than 20%. So most of the smokers can smoke most of their life and they don't develop emphysema or COPD. It's a percentage that is between 16 to 20%. So you can argue both ways. I say you have a normal CT, even if they smoke, you say this is one of those patients that smoking didn't affect their lungs, because not everybody who smokes has bad lungs. Now, the bronchoscopy, again, as I mentioned shortly in the presentation, if you have somebody with a heavy smoking history and you get all of this black BAL, I can say probably they smoke a lot more than what you were told, and it's significant anthracosis. Obviously, you can see that on heavily polluted areas with high contamination. You can see that, but if somebody that is a smoker, I will be careful with those ones.
Okay, thank you very much. Should donors automatically be covered in antifungals and antibiotics?
My answer is, again, and people can argue this, but I think that is a no-brainer. Antibiotics for sure. And my argument to everybody is say, okay, these same lungs that you are just giving me, as soon as I receive them, I'm going to have them on antibiotics, and you will help me if we have antibiotics in there. Many of these patients develop, again, some type of pneumonias at the time of death, again, as a result of aspiration or as a result of being on the ventilator for a few days. If they have any infiltrate on the x-rays, the definitions and the recommendations from the critical care societies and the infectious disease societies is that that's a definition of ventilator-associated pneumonia, and all of them should be on antibiotics. So to me, everybody, unless that you say that has a pristine, absolutely clear chest x-ray that was intubated electively in the OR for some type of surgical resection and an aneurysm, and that the x-rays are pristine, you may say, again, probably there is no reason for antibiotics in that, but that's the rare minority of patients. Most of them are going to have an abnormal x-rays when the report is going to say we cannot define atelectasis versus pneumonia. And if you see a report like that, all of those should be in antimicrobials. Antifungals is a different story, and that's the value of the bronchoscopy too. If you don't find fungal particles, again, on your ear like Candida or Aspergillus or Crypto or any other type of fungus on the BAL, there is no reason for the actual donors to be on antifungals.
Thank you so much. Another question asks, what are your thoughts on proning all donors?
Okay. Many of you may not like this answer, but I'm going to explain my argument about this. My answer is no. And my answer is no, because I'm never going to prone one of my recipients. And if I need to get lungs that have to be pronated to function, those lungs have a significant problem. And my goal when I go through all of these education sessions about organ donation for lungs, our goal when we do all of this donor management is to provide good lungs to a donor, to a recipient from a donor. So we want to give this recipient lungs that we feel that are good lungs. And to me, good lungs are lungs that have this good PFR ratio, that are fairly compliant on the ventilator, relatively easy to ventilate. Maybe that were hard to ventilate when we start the case, but then when we de-risk the patient, release all the mucus plugging, improve the atelectasis, took care of some of the pneumonia, at the end you have lungs that with a tidal volume of 500, 550 have peak pressures in the low 20s, and the 18, 19, with a PEEP of 8 to 10, you have great PaO2. Those are no prone lungs. So if you, in some point, again, you want to be very aggressive at the early management of the donor and do some proning and stuff like that, you are welcome to do it. But by the time that you are offering these lungs, you have to say these lungs do extremely well under supine conditions, because that's the way that our recipient is going to be. And this again goes into this APRB and all of those that, again, we receive a lot of donors from one of the OPOs that does a lot of APRB, and they cannot change their mode to do APRB. Our recipients are not on APRB. Our recipients are in conventional ventilation with pressure control, with normal settings of volume control, and their standard ventilation, because that's what we want to provide them, lungs that are easy to ventilate. And if you need to do proning, APRB, reverse ratios, 8:1, and things like that, it's not the idea. So I'm not trying to just make a bad lung looks good to get a transplant program to take it for the point to just placing organs. All we are trying to do is say this lung has the potential to be a good donor. Let's do all of these things that we are mentioning: fluid management, recruitment, ventilator management, bronchoscopy, put all together to be at the end when we are offering these lungs that we feel fairly comfortable for that. So unfortunately, again, I just give you a very long answer, but to me is I don't like it, unless if you want to do it early, it's fine. If they were doing proning before, it's fine. But by the time that you are offering these lungs, patients should be under relatively standard mechanical ventilation. We prefer pressure control in our OPOs. You want to do volume control, you can still do it with a good PEEP, minimal PEEP of 8. And if you have a good lungs with that, all the numbers should be looking okay. The X-ray should be acceptable. And none of these reverse ratios, proning, and things like that. If there is somebody, again, from the OPOs that do APRB, I'm sure that they 100% disagree with me. But that's okay too. We don't have to agree on every aspect of organ donation.
Thank you so much. I think we have time. And so if we didn't get to your question today, don't worry. We'll be sure to answer all of those in a follow-up email or blog post. So for our last question, Dr. Angel, do you perform bronchoscopy on only brain dead donors or DCD cases as well?
That, again, obviously we do in the deceased donors, that's what we do, and we try to do multiple bronchoscopies if possible. The DCDs are a little bit more complicated because these are different philosophies in different hospitals. Our lung donor management or donor management center here at the NYU, we have a lot of patients who are transferred. Some of those patients are being transferred for DCD, organ donation, when there is a family or somebody that is fully committed to organ donation, even on DCDs. So when they come here, we implement all the donor management protocols and we do bronchoscopies in those, and we don't have any issue because we understand they come to our center because they really want to maximize the potential of organ donation. And when we talk to the families, we say we're going to do some procedures. They are not going to affect a lot of the care. And it's not going to, again, change the fact that we are going to do remove all the support to the patient. But we want to maximize these things. So we do bronchoscopies on those patients, on those DCDs. However, in many other hospitals, even in our same OPO, we are not even allowed to touch those donors, or even to do any recruitment, to do, any management. And then in those, we don't do bronchoscopies.
Great. Well, thank you, everyone, especially Dr. Angel. Absolutely incredible information, the presentation, the data, absolutely everything. I think we could stay on with you for hours and hours. I just want to echo what Dr. Angel says of all of you out there doing all the really hard work in organ donation. I know that the other group of our doctors that work with many of you have probably talked to many of you in the middle of the night, holidays, weekends. So just, remember, we're all here to assist you. A quick programming note, if you will. We're going to continue these series. The next one is going to be heart caths in the importance of donor management. So any of you that are on this list, we'll make sure you get the invite. That'll be towards the end of August. But again, we will continue the whole bronchoscopy conversation, following up in more webinars like this with Dr. Angel. And again, we just can't thank you enough for joining us, everyone, and all the work that you do. And again, thank you so much, Dr. Angel. And we'll send out the information soon. Thank you.
Well, thank you, and it's incredible to have so many people listening to this, which is very encouraging. Again, it's so important, lung management. I think that for all of your organizations, there's always this feeling of accomplishment when you have a donor in which you can procure lungs. and seeing again so many of you just willing to listen and hear my presentation is very encouraging, and best luck to everybody.